endovascular cooling, reperfusion injury, imaging, and physiology. We all know that primary PCI is the ultimate evidence-based therapy in STEMI, and we need to do it in a timely and quality reperfusion achievement. We know about the role of primary PCI and the role of pharmacoinvasive strategy, which is probably the most practical in our country. We also should discuss about the culprit only or complete revascularization and when we should do it. And of course, the new is about the time delays, how to reduce them. More emphasis is on in-ambulance thrombolysis, and we should be making efforts to go in this direction. Adjunctive medication, we're all well aware. As for the primary PCI is concerned, good practices, the latest advances, and appropriate use of physiology and imaging is encouraged. And we'll discuss about the culprit and complete also. Regarding the other issues, beyond achieving reperfusion, we need to do the metabolic management to accrue more benefits in to save the LV muscle and the pump function and to prevent long-term heart failure and its sequelae. So here, one step is endovascular therapy, hypothermia, which we'll touch upon. We'll touch upon remote ischemic preconditioning and post-conditioning, and a small point about platelet paradox. We know that majority of STEMIs have multivessel disease, and almost 53%. And if they are not treated, they do worse. So if you treat more of these multivessels during MI, they do better. Whether to do it in the same sitting as a primary or not is the focus now. The other thing is, if at all we have to do them, when should we do it? And how to decide which vessel to do, and then how we should be doing it as well. So we know that if you take care of the other important non-culprit lesions also at the time of infarct-related artery primary PCI, the outcomes are better. There's no doubt about that. But when should we do it? If we start doing it only during the index admission, index procedure, if we start doing it in the index procedure along with the primary PCI, the data shows maybe it is not that good because the mortality is more. This is the observational London data, and you can also see the registry data, which shows that probably IRA PCI alone is better off than doing as a single stage completion. And the randomized data, if you see the PRAMI and the culprit 2 trials, the angiography guided trials, where primary has been done during index procedure, if you do the other vessel also, then non-culprit important severe lesions was doing fairly well. In this trial, it showed that it was good enough. In culprit, it was not mandated to do it in the index procedure when you were done in index admission. Before discharge, you do the primary, and before discharge, you get them back and then complete the procedure. Angiography-based decisions, it was doing very well as well. The MACE was better. What about the complete trial? This is a slightly different trial in the sense that majority here, again, primary PCI, then you randomize and decide whether to do the staged PCI either before discharge or after discharge, even up to 45 days. That was the cutoff here. And what happened? If you just complete the revascularization within 45 days versus only medical therapy beyond primary PCI for the infarct-related artery, the results were very clear. At whatever time frame you do the procedure, a completion of revascularization was translating into benefits in terms of reduction in mortality and re-MIs as well. Apart from, of course, the need for revascularizations. If you see all the previous trials, they showed that the need for urgent revascularizations was reduced. That was a major achievement in those trials of completion, what we had dealt with. But complete for the first time has shown that death and MI also could be reduced if you do the completion of the procedure. And definitely you can do it as a staged procedure, either before discharge or within the next 6 weeks or so. This is again an angiography-based decision-making trial. So how to decide? Now we know that we have to complete the revascularization, and maybe you can do it pre-discharge or within 6 weeks, but then how to decide which non-culprit vessel needs PCI? Is angiography-based decision, like in these 3 trials we have discussed now, good enough? Or we should be using something like FFR? We do have FFR-based decision-making trials as well. Theoretically, the limitation with an angiography-based trial is the minimal lumen diameter. The vessel size might look smaller during the acute MI, the non-culprit vessels, and also the stenosis might be overrepresented. So spasm might be there as well. But what about FFR in acute MI? Again, there are limitations, especially if we take an antiviral MI, the microvascular resistance might be not be able to be reduced by the adenosine. So FFR might not be a great reflective of a great quality procedure in acute MI scenario. This was always there, but then there was some data showing that FFR during an acute MI also was reproducible. You repeat it later, it was coming out well. In a non-STEMI scenario, we have data to show that FFR during acute as well as redone after some time was still reflective. So you could use an FFR guided procedure for guiding revascularization. That was the background. And in STEMI, we have two trials. One is the Dynamic 3 Primal T, where after the infarct-related primary PCI, in the index admission itself, an FFR-guided PCI was done later. So before discharge, again translated into a reduction in MACE compared to only IRA. So here, even though the decision to complete the revascularization was based on FFR, the procedure was done before discharge. It is not a single-stage procedure. So this was good. Whether it was 2 or 3 vessel or less than 90, more than 90%, FFR guided completion of revascularization was superior to incomplete revascularization. What about compare acute? The similar thing, FFR guided index procedure, they did it in the index procedure, FFR guided completion was good. But which is better, angiographic based completion or FFR guided completion? There was no comparative trial till FLEVR-MI came. FLEVR-MI is interesting because for the first time in this scenario of primary, you complete the primary and then decide, should I go for completion based on angio or should I go for completion based on FFR for the non-complete results and then see. And the outcome was assessed at 1, 6, and 12 months follow-up. Primary outcome was death, non-fatal MI, repeat revascularization at 12 months. This result was very, very important for practical reasons, because this is one issue we deal with on a regular basis. FFR versus angio-guided completion, 1 year, no significance statistically. You can see that. But the MI was slightly more in the FFR-guided arm. Urgent revascularization was slightly more in the FFR-guided arm. And if you see the curves, even though statistically not significant, at around 6 months' time, there starts a divergence in the graphs. The angiography-guided PCI arm started to do better. The FFR-guided PCI arm had more MACE. So this is something one has to keep in mind. This is a cause for concern, because if you follow them up for longer term, maybe the curves might diverge even more. One trial, of course, the full revasc, the results are not yet out. This is again a complete trial-like scenario, but only FFR-guided completion of the PCI. So here, the only one trial which compared these two showed that probably completion can be done by angiography itself. How do we do the completion? Should we use IVUS and OCT in all these cases? Does it help? If you see the PROSPECT IVUS study, there was some data showing that non-complete lesions, we can assess some features more by IVUS or by OCT. But then if you there's only one registry there, the Kyoto AMI registry, IVUS guidance based versus angiographic guidance in primary PCI, absolutely no statistical benefit or superiority or inferiority for any of them. After adjusting for confounders, no significant differences. The other was the one published from the US, Khalid et al., where again in-hospital mortality between IVUS guided and non-IVUS angiography guided was similar. A small concern here is those who underwent PCI with IVUS were slightly more likely to have coronary artery dissection with an odds ratio of 4.26. What about erosion 3, which is a randomized trial of OCT guided intervention in STEMI patients with early infarct artery patency? This is only for those MIs, STEMI, where already TIMI3 flow is there and the artery is opened up, less than 70% stenosis is there. You do an OCT, and maybe if you can avoid stents in about 15% of these patients, that can be done. But then this is based on tentative criteria, and we don't have any hard endpoints to follow. So there is no conclusive evidence to say that if you do imaging to guide your procedure, it's beneficial in STEMI. What about the future? I think the future will be a combination of physiology and imaging. We are going towards OCT-based morpho-functional assessment, where probably if you start going in and using the optical flow ratio, which will be a flow ratio based on the OCT, probably we can identify patients where this is needed, non-complete lesion completion is needed in a better way. What about cooling therapy? We know that once we achieve reperfusion, it's not enough because you have to protect the myocardium. Many a time, this reperfusion itself can cause injury. This probably accounts for about 25% of the damage to the muscle. We can reduce it by preservation of the myocardium, like with the out-of-hospital cardiac arrest and neuroprotection. This concept was tried in multiple trials, the COOL-MI and all that, where you bring down the core temperature to 32 with IV loading of saline and rewarm over the next 3 to 6 hours. The trial has shown there is an infarct size reduction in terms of enzymes, but then all the endpoints were very, very negative. This is the summary of the therapeutic hypothermia trials. All of them showed finally nothing major could be achieved by them. One point on the great platelet paradox. We all know that platelet inhibition is very crucial and of paramount importance in acute MI. But then we also know that beyond that acute phase, in the early stages, we need platelets for delivering some beneficial effects in terms of cardiac regeneration. This is the classical platelet paradox. And interestingly, the platelet paradox was when applied to the differentiation between the different P2Y12 inhibitors along with aspirin, ticagrelor somehow was showing a protection of the platelet preservation efficacy or benefit in terms of platelet paradox compared to clopidogrel or prasugrel. This is in early data, and we need longer data for that. Remote ischemic preconditioning using BP cuff for inflation in the left arm, 5 minutes each, inflation and deflation for 200 millimeters mercury, starting from admission in ER, and then carry out through the primary PCA procedure. Has been tried, again, theoretically good, but then it has not shown any improvement. So the take home, primary PCI is very important. Pharmacoinvasive therapy is good. We have to do it with least delays. Completion of revascularization of all angiographically severe lesions should be done either before discharge or within the next 6 weeks as a staged procedure. FFR or imaging may be useful in some borderline intermediate lesions or where ambiguity is there, but as a routine practice to be implemented, we don't have much data till now. Of course, data is going to come up. Morpho-functional imaging might show the future. Endovascular hypothermia, remote ischemic preconditioning still are in the dormant stage. Thank you.